Good morning. Professor has some emergency situation to deal with back to Shanghai. So I'm Dr. Zhang Hu from Shanghai Institute Hematology Regional Hospital. It's my honor to represent Team Profession and our institute to give this talk, the breakthrough in the treatment of acute primary leukemia. I will mostly focus on the role of arsenic in the frontline treatment for this specific disease. So first, I will simply overview the treatment of acute primary leukemia in China, and then I will talk about the results of arsenic as a first-line treatment for newly diagnosed patient, and then I will present some data on how to optimization of arsenic as a front-line treatment for these diseases, and finally, I will present some ongoing clinical trials in China. In China, mostly we are dealing this newly diagnosed patient with two major regimens. One is based on retinoic acid and combined with chemotherapy, and also we have another major regimen is combined retinoic acid and arsenic as a frontline therapy. This is included in the consensus guideline made by the Chinese Society of Hematology. And we all familiar with this regimen, retinoic acid combined with chemotherapy. This is a slide from actually Professor Thomas' review to present different kind of large-scale clinical trial to demonstrate this combination will result in quite satisfactory complete remission rate and long-term survival. But even though this much improved overall results, there was still sizable patients with relapse. So in China, we have another major regimen that means use arsenic as a first-line treatment. Actually, the rationale to use arsenic into a frontline treatment is based on the clinical data of arsenic initial study in the relapsed patient, which resulted in a very high complete remission rate and long-term survival. And in the initial newly diagnosed patient, the small-scale study also showed that single-agent arsenic can induce quite high complete remission rate and long-term survival. And in the laboratory study, there was a clear evidence to show that arsenic can induce degradation of PMR for oncoprotein, which can induce cell differentiation and apoptosis. And the DACE group in Paris have shown very clearly that arsenic trioxide is very effective in inhibition and clearance of leukemia stem cell or leukemia initial stem cell in mice model. So this is our first initial trial random study to combine retinoic acid and arsenic as an induction therapy. You can see here these three different groups using a quite similar dose of Ultra and arsenic, and the complete remission rate is similar, more than 90%. And combined with Ultra and arsenic, we achieve a much rapid complete remission. Median day 26 is 1 or 2 weeks shorter than retinoic acid arsenic alone. And following that study, we have developed a new protocol use arsenic as part of induction and maintenance therapy. As induction therapy, we combine Ultra and arsenic. And in consolidation, we're giving patients 3 sequential cycle of chemotherapy, daunorubicin, RC, and herohinotonin. And in the maintenance therapy, we're giving patients 5 cycle of 3 months sequential maintenance. The first month is retinoic acid, the second month arsenic trioxide, and the third month is low-dose chemotherapy. And this is our data we present a couple of years ago. We involve 85 newly diagnosed patients. The complete remission rate is 95%. Overall, the survival and disease-free survival is about 90%. And when we focus on those 8 patients who receive complete remission, the long-term survival is 95%. So this is quite promising data. And more importantly, we monitor quite closely the arsenic concentration, because this is long-term use of arsenic maintenance or raise a very critical issue is the arsenic-associated toxicity. So here we show that when compare those patients on the arsenic treatment, when patients stop treatment, the concentration of arsenic in plasma, urine, nail, and hair decreased significantly, though they were slightly higher than their normal control, healthy control, but all these levels are within the safety level. And we, up to now, we didn't document any arsenic-associated long-term toxicity, particularly different kind of cancer. So with this data, there's more and more report coming out to use arsenic as a frontline treatment. But even with this promising data, there was still a lot of problems we need to clarify. First, what is the best timing of treatment using arsenic? Does the arsenic is necessary for induction, consolidation, or maintenance phase? What is the optimal total dose of arsenic? They still don't know. Does arsenic monotherapy or it's necessary to combine with retinol acid or chemotherapy? If we combine arsenic with retinol acid, does chemotherapy is required for treating this patient? And then a very interesting development is, besides IV arsenic in mainland China and here in Hong Kong, we developed some oral formula for arsenic. So here I just summarize several important publications. You will see in our hospital we are using arsenic as part of induction therapy and maintenance therapy, total cycle of 6. And in AML Anderson report by Dr. Eastay, they are using combination retinol acid and arsenic in both induction and consolidation with a total cycle of 5. And in the North American intergroup study, they are combined retinol acid and arsenic as a 2 cycle of consolidation. And there was also a quite interesting report here from Hong Kong. They are using oral arsenic as a maintenance phase, but using different schedule. Oral arsenic 2 weeks every 2 months for 2 years. I calculate is almost 12 cycles. And also there was single arsenic treatment from group from Iran and India. They are giving 6 to 8 cycle of total arsenic as induction and post-remission. So there was all different kind of using arsenic in different phase of treatment, and with different schedule and different total dose. And here is the results. You will see overall the patient number, the complete remission rate is about 90%, and disease-free survival is quite good, around 90%. And the single treatment seems to be a little bit lower, but still around 60 to 70% enjoy long-term overall survival. And when we choose arsenic as a frontline therapy, it is now recommended to combine at least with retinol acid. Here is our laboratory study. We have been able to show that the retinol acid and arsenic have a synergy in the degradation of PMRA alpha, and which is not only important to induce cell differentiation and apoptosis, and this degradation of PMRA alpha is critical to eradicate leukemia stem cell, which has been shown by this group. Actually, if blocking this PMRA alpha degradation by proteasome inhibitor bortezomib will eradicate the efficacy of arsenic in mouse model. And the other synergy is shown here, that ARTRA can induce a specific gene, AQP9 gene expression, which will increase the cell sensitivity to arsenic. Here we show in some patients during the diagnosis there was no AQP9 expression, and during the induction and consolidation you will see a high level of AQP9 gene induced by retinoic acid. And in the laboratory study and the mice model, Scott Kogan summarized quite well the different model in a different effect of therapeutic strategy in the model, and which may predict the clinical outcome. For example, for retinoic acid, this is mostly a transactivation for PMR-alpha with weak degradation of PMR-alpha protein, so has a very significant effect to induce differentiation, but no or weak elimination for leukemia stem cell. And then the long-term treatment of retinoid alone will eventually have a relatively high rate of relapse. But when you combine it with arsenic, this is mostly a degradation of PMR-alpha protein, not only induce differentiation, but rapid eradication of leukemia stem cell, and then which may associate with a higher rate of cure of disease. So based on all this data, it seems to be that arsenic combined with retinoic acid seems to be a quite promising treatment strategy for newly diagnosed APL. So if the data is so promising, does this combination can get rid of chemotherapy? Because when we adding arsenic, we may have some more side effect of arsenic. And if we can get rid of chemotherapy, this will be a very appealing concept, because we are treating a disease or even cure a leukemia just by giving patient differentiation or apoptosis induction agent, not cytotoxic drugs. So this is a very appealing concept. And it may reduce the toxicity of chemotherapy, and this definitely will reduce the cost of treatment, at least in mainland China, because I know in China the cost of arsenic is cheap. It's not so expensive, but it's not exactly the same in United States or Europe. There's data from East Group. They study using a combination of ultra and arsenic, but of notice, you will see the upper line is good risk or low risk patient that is defined by less than 10,000 white blood count before the treatment. But for high risk patient, you will see the overall survival rate seems to be not so high. So our guess is that at least for low risk patient, probably ultra and arsenic may be sufficient treatment for this patient, but we need a clinical trial to confirm that. But for high-risk patient, maybe ultra and arsenic alone are not sufficient enough, and we need to add at least some chemotherapy to maintain or further improve the treatment, the outcome. And the other interesting breakthrough in mainland China and Hong Kong is the development of oral arsenic formula. This is more convenient for those patients. And this is the earliest study from Peking University by Professor Lu. He showed that in those patients who receive a hematologic complete remission and put on oral arsenic, the arsenic sulfide post-remission therapy, the disease-free survival is quite good, over 80%. And here is the data from Hong Kong. They just published last year. They are using this oral arsenic solution as a maintenance therapy, and they are leading to about 80% overall survival and more than 60 event-free survival. So with all this emerging data, we can see we still need to perform multiple clinical trials to confirm all this data and to well establish those unsolved issues. And finally, I will present one clinical trial is ongoing, which is quite interesting. And this is a multi-center study at national level, part of A73 key program in leukemia. And we are part of this study, and this study is led by Professor Xiaojun Huang from Peking University. Actually, this couple of slides is kindly provided by him. And this is a very simple study designed to randomize patient to directly compare IV arsenic trioxide and oral arsenic sulfide. So both patients will receive and arsenic as induction therapy, and then giving 3 sequential chemotherapy as consolidation, and followed by 2 years maintenance with arsenic and ultra sequential maintenance. This is the patient characteristics. There was no big difference between the arsenic group and arsenic sulfide group. Sorry, there was some Chinese character. But this is their update on induction therapy. There was more than 110 patients in the arsenic sulfide group and 120 in IV arsenic group. Both complete remission rate is quite high, 98%. The time to complete remission date is similar. There was a trend of a higher molecular complete remission at the end of induction therapy in the IV arsenic group. But after consolidation chemotherapy, in both groups, 100% of patients achieve molecular complete remission. The median follow-up is 20 months in each group. And here is the survival curve. It's extremely good. The predicted 3-year survival is remain 98%. So this is so far the best results we can get from literature. And I think this trial is already complete enrollment, and we are still following those patients. We hope we can get this published in a couple of years. And after this study, we are now designing a new study trying to confirm our speculation that in low-risk patients, arsenic maybe combined with ultra can replacing chemotherapy as a major treatment. So for low-risk patient, we plan to randomize patient with ultra plus idarubicin 2 cycle as a consolidation, compared to ultra plus arsenic trioxide. And when the patient receives complete remission, molecular remission rate will kick on the maintenance with ultra and arsenic trioxide. And for high-risk patients, we're still adding idarubicin and RC and 3 cycle as consolidation, and compared to retinol acid plus arsenic with idarubicin. In that case, we are trying to answer a question: does adding arsenic into high-risk patient can replacing cytarabine at least to take off one chemotherapy agent? To summarize the presentation, in China, arsenic as a frontline therapy improved long-term survival, and we need to further optimization of use arsenic in acute primary leukemia. There were several ways to further optimization. First is try to confirm the oral arsenic. Though the promising preliminary data we need to see the final data, and then we can make conclusion: does the oral arsenic can replacing the IV arsenic? And sorry, this is a mistake. And then we are trying to develop a risk-adapted strategy. That means using retinoic acid and arsenic for low-risk patients, and the retinoic acid, arsenic, and chemo for high-risk patients. Besides the efficacy, we need to focus also on the long-term toxicity of arsenic. So all these clinical trials should follow the arsenic concentration and arsenic-associated toxicity quite closely. Finally, I want to thank Professor Chen and Professor Wang, long-term mentor, and also Dr. Liu, Dr. Wu, who have performed a clinical study and laboratory study and generated this data. And also thank Dr. Zhu and Dr. Huang from Peking University to kindly provide the slides of latest clinical trials. Thank you.